Well, first off, some key concepts. Vasospasm is a large artery delayed onset narrowing, peaking about a week to 10 days after subarachnoid hemorrhage. The underlying cause is almost always cerebral aneurysm rupture, as that is the usual cause of the large volume subarachnoid hemorrhages that can fill up the subarachnoid cisterns and thickly encase the arteries traveling within them. The serious risk of vasospasm is narrowing severe enough to cause delayed cerebral ischemia, the second stroke after the first stroke, which was the aneurysm rupture. Subarachnoid hemorrhage management principles include the following: maintenance of a normal circulating blood volume, normal blood pressure, and normal as possible intracranial pressure. In other words, preventing hypovolemia, hypotension, and elevated ICPs. We can monitor vasospasm development with transcranial Doppler and vascular imaging and perfusion, but the most reliable way of detecting early ischemia in the awake patient is the bedside neurological exam. Vasospasm prevention and treatment with so-called Triple H therapy, which is deliberate hypervolemia, hypertension, and hemodilution, is not recommended for routine subarachnoid hemorrhage management, although induced hypertension is important in infarct prevention once signs appear. Cerebral ischemia signs need to be reversed promptly with induced hypertension with vasopressors, and if signs do not reverse within 1 hour, plans should be made for a CT scan, CT angiogram, and the possibility of endovascular therapy. Failure of these measures to improve the patient's condition might mean you have the wrong diagnosis for the patient's worsening, or that the ischemia has in fact progressed to an established infarction. Definitions and terminology are as follows. Angiographic vasospasm is arterial narrowing seen on vascular imaging, beginning days following subarachnoid hemorrhage and peaking in severity at 7 to 10 days. Clinical or symptomatic vasospasm, or delayed cerebral ischemia, is narrowing causing ischemia with corresponding neurological signs. It's important to remember that vasospasm is just one of a number of causes of delayed onset worsening after aneurysm rupture. In the past, it has been overdiagnosed, blamed for more morbidity than can be attributed to it. Having said that, its delayed and usually gradual onset provides a unique opportunity for prevention and/or reversal. It remains an important cause of poor outcome after aneurysm rupture. And finally, and as we shall discuss, its precise pathogenesis remain incompletely understood. Vasospasm is common. Almost every patient with visible subarachnoid blood after aneurysm rupture will develop at least a degree of arterial narrowing, but it varies in severity and distribution. As an easy to remember, if rough rule of thumb, at least moderate vasospasm, that is somewhere between 25 and 50% narrowing compared to baseline, will occur in about 2/3 of patients after aneurysm rupture. 1/2 of these will develop symptomatic ischemia, and 1/2 of these patients will either die or suffer permanent harm from cerebral infarction. The prevailing opinion is that vasospasm is indeed vasospasm, in other words, smooth muscle cell contraction, although chronic contraction, and therefore not ATP or calcium dependent. The cause for this contraction is thought to lie in endothelial damage and dysfunction as the result of periarterial blood clot and the release of all of their noxious stimuli and in particular as oxyhemoglobin oxidizes, breaks down, and produces anion radicals. Free radical damage causes a combined reduction in natural nitric oxide synthesis by endothelial cells, nitric oxide being a potent vasodilator, and overproduction of endothelin-1 by endothelial cells, endothelin-1 being a peptide that is a powerful vasoconstrictor. If vessel wall inflammation and/or remodeling have any role, it is likely a minor one. This is a list of risk factors for vasospasm, and as you can see, the top and most important 4 are all related to the severity of aneurysm bleeding. Larger clot volumes and distribution, a slow rate of clot clearance, a loss of consciousness with rupture, and a poor neurological grade on admission. There is evidence also that unhealthy blood vessels, due to cigarette smoking, pre-existing hypertension, or diabetes, are either more susceptible to vasospasm, or that the brain they supply less tolerant of vasospasm, so that ischemia is more common. This is a modification of Miller-Fisher's original scale for vasospasm risk, and it remains very useful at the bedside. The highest risk patients are those with thick and widely spread blood clot, both in the subarachnoid space and ventricles, which is quickly and easily identified on the admission CT scan. Signs of ischemia tend to be gradual, subtle to start with, hard to put your finger on, but a change in patient status nevertheless. Rarely deterioration is precipitous, over minutes rather than hours. Middle cerebral artery vasospasm is perhaps the easiest to recognize, with lateralizing weakness and dysphasia if the dominant hemisphere is affected. Anterior cerebral artery vasospasm is a little harder, but it's usually bilateral, so bifrontal ischemia can cause headache, somnolence, confusion, poverty of speech, and eventually lower extremity weakness, which can be bilateral. The real problem patients in terms of clinical recognition are those in poor grade who are difficult to examine, often sedated and intubated. Especially problematic are those patients already made hemiparetic from primary damage, intracerebral hemorrhage, or complications associated with aneurysm repair. In these patients, we need to rely more heavily on repeat imaging and vascular monitoring. There is a substantial list of other causes of delayed deterioration which must be considered. For example, sepsis, hypoxia, and sodium disturbances can magnify existing deficits and masquerade as delayed ischemia. And at the same time, they can aggravate developing ischemia, but in both cases need to be recognized and treated. Cortical spreading depression is an incompletely understood brain condition that has been associated with subarachnoid hemorrhage during the vasospastic interval, causing delayed deficits but unassociated with large or small artery vasospasm, and probably accounting for the occasional patient who has no vasospasm or indeed any other recognizable metabolic disturbance from this list, yet has distinct and delayed deterioration in their condition. This is a list of brain and/or cerebral vascular monitoring techniques which have been employed following subarachnoid hemorrhage in the hope of recognizing developing vasospasm. Transcranial Doppler, or TCD, is perhaps the commonest modality, working on the principle using Doppler shift that as a vessel narrows, the velocity of blood transmitted within it increases. To help distinguish a generalized body increase in blood flow and therefore blood velocities from intracranial vasospasm, the Lindegaard ratio can be used as shown. This makes a ratio of the middle cerebral artery over internal carotid artery velocities with values over 3 indicative of at least mild to moderate vasospasm. It's a simple and useful monitoring method, but it does require a skilled, consistent technician, an adequate bony acoustic window, and a consideration for other factors that can influence the measurements, such as blood and intracranial pressures. But a dangerous day-to-day trend in the vasospastic interval in a high-risk patient is a significant concern and warrants vascular imaging early rather than too late. When it comes to vasospasm, there is nothing superior to angiography itself, comparing vessel calibers to baseline. CT angiography is the most convenient and also provides another look at brain condition, helping to rule out other causes of neurological change. Even taking into consideration clip or coil artifact, it certainly detects significant vasospasm, and it can be repeated providing the patient has satisfactory renal function to accommodate the contrast level. Another commonly used test is CT perfusion, although it's difficult to perform this daily. If timed properly, it can be quite helpful in the difficult to examine patient. Near-infrared spectroscopy, brain oxygen probes, microdialysis brain catheters, and continuous EEG are more demanding methodologies. And the first three only interrogate a quite small volume of brain, usually in the anterior frontal lobe cortex, and this is a major limitation. If you have the personnel and expertise, continuous EEG can also be helpful in sedated, intubated patients. General management of aneurysmal subarachnoid hemorrhage includes all of these: avoidance of hypovolemia, systemic hypotension, intracranial hypertension, and hypoxemia, as well as correction of any sodium disturbances, and avoiding anemia, keeping the hemoglobin. Some promising agents failed to prove themselves in randomized controlled trials after aneurysmal subarachnoid hemorrhage, and consequently intrathecal vasodilators, including nimodipine, are not recommended, nor is magnesium sulfate or statin medications as vasospasm prophylaxis. The endothelin-1 antagonist clazosentan has shown some hope and continues to be studied experimentally in clinical studies. Corticosteroids and anticonvulsants should be avoided unless, of course, a patient has a documented seizure in which an anticonvulsant is indicated. In the event of a new neurological deficit, these are the questions which need to be asked and addressed. Has it lasted longer than an hour? Is it within the vasospastic interval, days 4 to 14 following subarachnoid hemorrhage? Has the differential diagnosis been ruled out, such as hypoxia, hyponatremia, sepsis? Has a CT head been done to rule out infarction, hemorrhage, or worsening edema? Is there any monitoring evidence to consult? For example, a trend in TCD velocities. And finally, is vascular or perfusion imaging warranted to help with the diagnosis? It's important to resist the temptation to blame every delayed deficit on arterial narrowing. In the past, vasospasm has been blamed for more morbidity than it has caused. However, if all indicators point to delayed cerebral ischemia, speed is of the essence, as with all types of ischemic stroke. Rescue or reversal treatment begins with ensuring that the patient is volume replete, but excessive hypervolemia is not recommended. Hypertension is recommended, and we will go through how that might be achieved. But very importantly, if a target blood pressure, typically 200 millimeters mercury systolic, fails to reverse signs promptly within minutes or at most within 2 hours, then endovascular treatment should be initiated. Failure to respond, however, is a reminder to consider other diagnoses or that an irreversible infarct has occurred. It bears repeating that the traditional combination Triple H therapy of forced hypervolemia causing hemodilution and hypertension is not a standard of care, as it has not been shown to be preventative or beneficial, but instead associated with hemodynamic and cardiorespiratory complications, namely pulmonary edema and congestive heart failure and strain. Hypertension can be achieved with a vasopressor such as norepinephrine or phenylephrine. But if target blood pressure fails to reverse signs within 1 hour, then move on to endovascular treatment, which is the subject of another chapter. The principles presented here are a summary, and additional context and information can be found in a corresponding chapter, The Medical Management of Cerebral Vasospasm, in Yeomans and Wynn Neurological Surgery, 8th edition. I have no disclosures or disclaimers pertaining to this presentation. Thank you for your attention.